Good morning, everyone. I'm Dr. Kushal, and my topic for today is a procedural guide for robotic assisted rectal surgery for rectal cancer using Indian SSI Mantra Robot. There's nothing to disclose. Minimal invasive surgery in rectal cancer has gained prominence owing to its various advantages and surgical outcome. Due to rapid adoption of robotics in rectal surgery, we intend to assess the feasibility of Indian SSI robotic mantra platform for rectal cancer surgeries. This marks the first comprehensive guide tailored for multicast open console system. This is the example of the operative theatre configuration. You can see we have given enough space for the robotic arms to maneuver. This photo represents the port placements. In the retraction arm, we have used a bariatric port for maximum maneuverability. Patient is positioned in Lloyd Davis modified lithotomy position. Before docking, we place the patient in maximum Trendelenburg with 15 degrees left up. This is the system deployment. For the abdominal phase, we have a centro-side docking, and for the pelvic phase, we have the central docking. We use the monopolar curve scissor and the fenestrated bipolar as our energy devices, and no other vessel sealing devices are used. This patient is a 54-year-old gentleman, carcinoma mid-rectum, T3N1. He received total neoadjuvant therapy and was planned for robotic low anterior resection. We start with the abdominal phase of the surgery. The IMA pedicle is lifted 45 degrees from the midline. A sharp cut is made on the peritoneum and the pneumo is allowed to enter the retroperitoneum. As the pneumo enters, it creates a space between the visceral layer and the parietal layer of pelvic fascia. You can clearly see the nerves which are under the parietal layer of pelvic fascia, and it is important not to just preserve the nerve but also fascia over it. We continue our dissection proximally and identify the lower border of the duodenum. We do the principal lymph node dissection, clearing all the lymph nodes from the origin of the IMA but carefully preserving the left colic artery. The IMA and the IMV are clipped and divided. After the vascular division, we continue the medial to lateral dissection over the Gerotas fascia, identifying the three tubular structure in that order of left common iliac artery, ureter, and the gonadal vessels. After completing the medial to lateral dissection, we do the line of toll division. We can clearly identify the left gonadal entering the deep ring laterally. Complete left colon mobilization can be achieved with the current port placement and the docking position without any internal or external clashing of the arms. Sharp dissection can be done over the Gerotas fascia and left colon can be easily mobilized. We start with the pelvic phase of the surgery. We hitch the bladder to the anterior abdominal wall and pass an umbilical tape under the rectum, which is held by the assistant for retraction. We continue sharp dissection in the plane of field, that is the posterior TME plane, clearly identifying the hypogastric nerve and preserving a thin layer of parietal fascia over it. You can clearly identify how easily we can achieve dissection deep in the pelvis. Extensive posterior dissection can be achieved with preservation of all the parasympathetic nerve erigantus fibers. After completing the extensive posterior dissection, we start the lateral dissection. We start initially on the right side, again identifying the fibers of the nerve erigantus and the inferior hypogastric plexus. Similarly, we do the dissection on the left side, and finally we do the dissection anteriorly between the two layers of the non-villous fascia. Again, we preserve a fascia over the seminal vesicle and the prostate to avoid injury to the cavernous nerves. Complete circumferential dissection is done up to the cherry red levator and eye muscle. We expose the bared rectal tube beyond the TME. After completing the circumferential dissection, we do a distal transaction using a stapler which is fired by the assistant. We externalize the specimen, place the anvil, and do a intracorporeal end-to-side anastomosis using circular stapler. You can clearly appreciate how easily we are able to throw a second layer over the anastomosis in a narrow, deep pelvis. In all, we have done a total of 57 cases as of now, and our results are comparable to the one when we have been doing on Da Vinci robot. The detailed description of the docking technique ensures smooth coordination between the surgical team and the robotic system, facilitating precise maneuverability during the procedure. This is one of the studies. Thank you for watching this video.
Kushal, great talk actually. But you've been using XI for a long time, so the only thing, the procedure remains the same. Only thing, because the patient cards are different, so actually you should concentrate more on how the patient card comes, because you're using the double docking for SI.
Correct, sir.
Did you have any problem with clashing, or if you wanted to do a full splenic flexure mobilization, did you have to move one arm on the other side, or it used the same thing?
So not shown in this video, but we are able to achieve a complete splenic flexure mobilization with the current foot placements and the central side docking which we do. One particular point is initially for initial 5 to 7 cases we did have some problem, but after completing more than 20 cases, when we have passed that learning curve, we know exactly where to dock and how to dock, and now we are pretty much comfortable, and the procedure remains the same whether we do it on Da Vinci or whether we do it on SSI. The individual patient cards are generally on the same side. As we see for the abdominal phase, it is on the left of the patient, and for the pelvic phase, we place it in front of the patient, in front of the leg. The idea is that we have a vast experience with Da Vinci robot, and it was relatively easy for us to shift to SSI robot. Anybody who's starting with the SSI robot directly might find it difficult. But because we have a dedicated robotic team and a dedicated, not just the doctors, but also the OT technicians which take care of the robots.
So is the clashing of arms less with individual patient cards compared to XI? I'm just asking because we have to start sometime next week as well.
Yeah. It depends. We have to make the robot work for us. Initially, when we started, we found that there were more clashings with the individual arms rather than having less clashings, because if you look, the robot seems to be bulkier as compared to the single pillar robot, and for the same reason we had more clashings. But now, because we have been very particular about our docking and port placements, we are able to achieve the full surgery without any clashings. Anything new will take at least 10 to 15 cases as a learning curve. We have to acknowledge that.
Yeah. Nice talk, Kushal. So you are saying you did a double docking?
Yes, yes. For rectum, we always do double docking.
Even
in the Da Vinci, we do single docking.
Yeah, you are able to do single, but
yeah.
Here you have not been able to do a single dock for it.
Yeah. For this particular robot, we have the newer version of Mantra Robot which is coming, which is the Mantra 3, which has got thinner arms and slimmer and longer arms. So we still haven't got it established at our institute. As we get it, we might attempt doing a single docking.
And do you use ICG for vascularity or anything?
Yes, so we don't have a incorporated ICG system in this Mantra robot. So we have to use the external store. So after distal transaction, we exteriorize the specimen and check it using our external near infrared probe for the vascular body.
Thank you. Thank you so much.
Good morning. I would say thanks Verticity Foundation for giving me opportunity. So my topic for today is efficient use of ICG and robotic platform for segmental resection of splenic flexure tumors. So traditionally, the splenic flexure tumors, the surgeons perform extended right hemicolectomy. Greetings from Plymouth and University Hospitals of Plymouth, where we work. Splenic flexure cancers are very rare, present late in advanced stage, and challenges related to dual lymphatic drainage. And only 14% of surgeons perform segmental resections. Rest of them, they do extended right hemicolectomy. The following paper, which was published in European multi-center propensity study, showed no difference were found in overall survival or disease-free survival between extended right hemicolectomy, left hemicolectomy, or segmental splenic flexure resection. But when we do extended right hemicolectomy, you remove the terminal ileum and ileocecal valve, which leads to vitamin B12 deficiency, which leads to macrocytic anemia and CNS dysfunction, bile acid and salt malabsorption, which leads to biliary diarrhea, and small intestinal bacterial overgrowth, which over a period of years I observed cognitive impairment. So this paper published from Japan, published in Lancet journal, shows the optimum bowel resection margin in colon cancer is 10 centimeters, which is sufficient. So my proposed study or a proposed procedure which I am doing now is segmental splenic flexure resection when compared to all the other procedures which has been recorded. So over a period of 3 years, I performed 16 patients as a segmental resection. Age range from 60 to 91, slight male predominance, and we have more tumors in T3 tumors, and 15 out of 16 patients we harvested more than 12 lymph nodes, and 3 patients had a lymph node metastasis, and our median length of stay is 6 days, and mean harvested lymph nodes are 23, and 15 out of 16 patients had more than 12 lymph nodes harvested. R0 resection in all the 16 patients. Complications or leak are nil. So I use an XI platform with a dual console for training, and I will show you 2 cases. First is a T3 tumor, case 1, and second is T4 tumor. First is a 76-year-old lady with a splenic flexure tumor. Position is slight head up and tilt towards the right, and targeting the robot to the splenic flexure. First tacking, mobilizing and injecting the ICG peritumorally with a diluted ICG, and first step is to mobilize the inferior mesenteric vein and clip the vein at the lower end of pancreas. Then mobilize the splenic flexure. Now we use the firefly technique to see the lymph node mapping and take the main pedicle, which is the left branch of middle colic artery. So once we got the pedicle, I move upwards and remove the lesser omentum for a radical resection. And this is a 10 centimeter clearance on either side of the tumor. And finally come to the splenic flexure, and without damaging the spleen, remove the splenic flexure. And final attachments, all the ligaments, the splenic ligaments are all removed. This is a proximal division and distal division. And use a stay suture and produce an isoperistaltic anastomosis. I use a green cartilage. So this patient had a bowel preparation. So I use a gauze piece, betadine soaked gauze piece to prevent any spillage. Slightly tilting the cartridge leads efficient firing, and use 2 V-lock sutures to close the enterotomy. And once I finish anastomosis, I cross-check again with ICG to make sure the good blood supply and cover the area with omentum. And the specimen is extracted through a phaneal incision. This is the second patient who's got a T4 tumor. Again, the ICG is injected peritumorally. Lymph nodes are mapped. IMB is taken down. And this tumor is very close to the lesser omentum, so had a good clearance. I use vessel sealer to take down the splenic flexure. Again, ICG check to take the proximal resection. I'm here using a Sureform stapler. And the distal resection. And the anastomosis, the same technique. So advantage of segmental resection: avoids unnecessary resection of the middle colic vessels and terminal ileum, preserves colonic length, decreased morbidity, faster recovery rates, and avoids incisional hernia, and better functional outcomes. Thank you.
Nice talk, Dr. Rajesh.
Thank you.
In your 16 cases, did you have any covering ileostomy for any of these?
No covering ileostomy.
Any indications in your practice for covering?
No. The covering stoma is only done for the lower rectal cancer. Otherwise, I have not done it.
Thanks, Rajesh. Great presentation. Sometimes when we do left colectomy, we always isolate the IMA and take the left colic at the root or something, but obviously segmental has the same results. I think for left hemicolectomy, internal herniation is a problem. Have you ever had any problem like this? Or?
No, I have 16 patients, touch wood, that is nothing happened, but isoperistaltic anastomosis, and I cover the area, and I also use momentum to cover that area. So I now come across the internal herniation.
Do you also inject ICG with colonoscopy like prior to this?
The problem with the colonoscopy with NHS, we don't have time to inject the ICG. So the first thing is it's better to inject ICG at the time of surgery, otherwise pre-operatively we need to inject beforehand. Because of the practicality, I'm not using that. Yeah. So ICG, we dilute, it comes with 25 milligram powder, and we dilute with 10 ml of sterile water. So here actually you need to dilute twice. First I inject with a saline bleb and give about 1 ml of ICG into that bleb. So diluted ICG will move into the lymphatics quickly. It takes about 20 minutes for the ICG to dissipate into the lymphatics and to show up the lymph nodes.
Thank you.
We have just tweaked it. We tend to use the retraction arm more laterally. We used to place it more medially in the suprapubic area of the retraction arm, which we place for the abdominal phase of the surgery. When we do it on the Da Vinci robot, we tend to place it more medially towards the midline. In the Mantra robot, we tend to place it more laterally towards the anterior superior iliac spine. That way, we personally found out that there is less clashing. Number two, we make sure that in the retraction arm, we use a bariatric port, because bariatric port, not because of the patient habitus, but because bariatric port is longer, and the longer the port, it gives us extra more space for the movement, extra more wider is what I can say. In fact, there have been situations in which we have used all the bariatric ports, because bariatric ports, it is like doing a nephrectomy or a partial nephrectomy, in which you tend to preferably use a bariatric port to give more space. So the similar concept we use, and our port placements have been more or less similar to what used to be for the Da Vinci robot. Nothing to do with the laparoscopy, sir, in this.
Thank you.
Yeah.
Thank you, sir. Wonderful presentation. Injecting ICG, have you ever used that to guide your lymph node dissection and see your lymph node harvest? And the other thing is, could you show your docking and targeting? How do you do the port placement and because it went too quickly in the video, I missed that.
The first question I'll answer, the second question I'll answer outside because shortness of time. The first question is the lymphatics mapping and the lymphatics which you have seen. I inject the ICG and wait for 20 minutes. So it gives me the mapping of all the lymphatics and lymph nodes, highest lymph nodes. So we can't get any sentinel lymph nodes out of it. It's only the area which we can map out. I inject for a proximal tumor, the transverse colon tumor, I inject it proximally, and for the distal tumors, I inject distally. So get a good coverage and radical resection. For the targeting and the position, I will come and discuss with you. Any more questions? Thank you.